difficulties. My name is Nicholas Leydon. I'm the Executive Director of the Kaizen Promotion Office up at the North Shore Medical Center. I'm based in Salem, Massachusetts, and we also have the Union Hospital campus in Lynn. Both come under the North Shore Medical Center. Some of the names I know folks from across the state. I hope it's sunny where you are. The sun is still peeking through here in Salem. Just a quick introduction about myself before we get started. I've been at North Shore Medical Center only a short time, really, since last August when we opened a Kaizen promotion office here at North Shore Medical Center. Prior to that was doing a host of things, including running, as the director, an AHRQ grant on medical malpractice in the primary care setting and ambulatory settings, and had a chance to work with some practices that we still have a chance to work with here on the North Shore, which is a nice connection. My history before that was largely with the Institute for Healthcare Improvement, which many of you probably know. So the tying in of their improvement methodology with the lean methods that we have here, we're utilizing in the North Shore is a really beautiful fit. We'll talk a little bit about that today. I'll go ahead and get started, and I imagine some others will join us as we go ahead. I believe we have an hour for this call. I'm going to endeavor to wrap up about 15 minutes before that time to leave a chance for folks to chime in and have a little bit of conversation. I understand that we usually leave the chat for technical issues, and then at the end you can write in your questions. So please hold, if you could, I guess, hold your questions until that time. I would normally like to be a little bit more conversational, but I know with 20 plus folks on the phone and then more potentially online, that it becomes a little cumbersome. So there's a somewhat unwieldy title here, but really what I'm hoping to do today is just share a little bit about our journey. And I had a chance to look at some of the previous sessions. This is part 3 in a series. I had a chance to look back while I wasn't joining you on the webinars for part 1 and 2. I saw that you, for those of you who have joined, you've seen a lot about statistical variation, the use of the tools, and those are critically important. And I think perhaps the way to spend some of the time today is to share a little bit about the journey of an organization and touch on some of the lessons we've learned even in the early stages of a lean journey and how that's reflective of the journey that came before it. So I hope that will be useful to you as you think about the journey of your own organization. Really, when we often talk about Six Sigma in lean, or really any improvement method, frequently the initial conversation is around throughput and efficiency and cost, and you even saw that in the title of the presentation here. And while that's true to a degree, we're learning these methods from a number of private industries, industries that have used methods for decades now to run and improve their business and deliver value to their customer. In our case, though, the customer, as we all know, is the patient. And just like Toyota wants to make sure that every car for every customer is perfect, we want to make sure the care for every patient is perfect. So one of the initial comments, really, about my journey here and about our organizational journey is really framing the conversation around Lean and Six Sigma to be a conversation on reducing variation and pulling out waste so we only deliver that which is necessary to the patient and that which is of value and of safety to the patient. Anything that gets in the way can harm or detract from the important things. So we believe that while we're looking at this from production and we're looking at it as flow, we still hold at the center of it that every patient is the only patient. And before we get into the agenda today, I've been reflecting a lot. I had shared a slide like this a few months ago with colleagues here, and as I was looking at it again last week, just laughing, given for all of us living in Massachusetts, and we've heard a little bit of the meltdown of our public transport system. We see at the top left here our Park Street. This is the MBTA when it opened, I believe, in the late 1800s. And for those of you who still ride it, you'll recognize down at the bottom the green line. Very much the same system. We've added a little bit of new technology and tried to keep up with the times. I'd argue that that's kind of the way our healthcare system's been built, which is we built something and we've added to it, but not necessarily always delivering the results that we need. But we put up with it because it's what we have and what we're used to. And I'd argue the one that we see on the right-hand side, which is Amtrak bullet train in the eastern corridor of the country, is really what the environmental landscape, policy, and patients are really asking of us. They're asking for something that's quieter, safer, faster, less disruptive, something that's more comfortable. And I mean that in a way that it respects them in their lives and is less disruptive in their lives. So I feel that much of our journey here in quality improvement for us as an organization has been a little bit of those first two images. It's that a system was built and that we've tried our best to make adjustments to keep atop of it and to be accommodating and to make improvements where we can. And in some ways, what we're headed towards is really a new rethink given what the landscape and our patients are demanding of us, given the complexity of care. So really quickly, wanted to share a bit about our overview, some key concepts. Upon further reflection, I realize you've covered much of that already in previous sessions. Talk about some lessons and experiences and then our journey ahead. An improvement journey is not necessarily new to North Shore Medical Center, as I'm sure all of your organizations are on some form of an improvement journey. From what I understand, our organization has dabbled with many. We've had many dance partners, even over a short amount of time. And a few of them are listed here. You may very well have relationships with these organizations. One of them I called home for a number of years. And they all offer a vision for change and some tools for change. And they're all, the way that I've interacted with all of them has all been very positive. The shift for our organization has been really a one of complete management change, not necessarily the people per se. It's the way of thinking about improvement. And really what I mean is that we had been in project-based improvement activity. A small group of people identify a seemingly pressing problem, somewhat within their sphere of influence, and they work on it, sometimes with help from people in a performance improvement team or elsewhere in the organization, maybe somebody who's gone out to a conference and has some skills, and you work to improve it. And you might see some results, or it might be a year of meetings once a month to try a test of change and not really sure where you left off, and we struggled a bit with that. And I've seen it elsewhere before joining NSMC. A few years ago, our primary care partners, the North Shore Physicians Group, started an engagement with the Virginia Mason Institute, which is the improvement arm of the Virginia Mason Medical Center in Seattle. And they've been on a 14 or 15-year journey now with Lean. And so the journey for us really started with our NSPG counterparts. And while they've finished their formal relationship with the Virginia Mason Institute, it certainly has helped accelerate and is a wonderful partnership to our work here in the hospital setting. So we opened a Kaizen promotion office in August. For those of you not familiar with it, or if you've missed previous sessions, Kaizen means good improvement. This is a term that's used in multiple industries, and we see our work really in 5 areas that are laid out here. The first is to be the keeper of the methods, to teach the organization. And while I won't go through them all in detail, these are some of the things for us at different levels, from orientation all the way through some advanced courses to teach throughout our organization. And this really starts with senior leadership to be sponsors of horizontal system-wide improvement. The second is for the Kaizen Promotion Office not to carry out the improvement, but to really ensure that the work happens. And this is to be a coach and to be to help with the data collection or really applying the tools that folks have learned to their methods. So I'll talk more about it, but we have three what we call value streams, which are our priority areas for the year. We also have a trust that supports some work here in Salem. That's the Albright Reed Institute. You see that mentioned there, ARI. And they have some other separate work, which is a little bit of more project-based. Again, this is an integration of the way we used to do things to the way we're planning to do things. So we're bringing those projects into the lean methodology. And then the last is supporting and coaching other North Shore Medical Center departments. So there are improvement projects still going on throughout the organization, and we're trying to do a balance of focusing on key priority areas, as mentioned above in the value streams, while also providing some support, some teaching and coaching to folks who are trying to have influence within their sphere. We see our job is to communicate our results and to communicate with folks the improvement journey that we're on through a variety of methods. And then lastly, as the executive director, I see my role as really ensuring that our team walks the walk. So to ensure that our team is a place where there's joy in work, that we're on budget, that our relationships are flawless, and that we use internal improvement applications to our own work. The last piece here is really trying to tie the activity of the four above, teach and learn, ensure results, communicate and manage, tie those directly for folks and make a clear line of sight between the work on the floor on any of these priority areas all the way up to our annual goals or strategic plan. Really quickly here, this is how we're organized. The reason I wanted to show this to you is because of our senior vice president is of operations, and that's the person who is oversees the Kaizen Promotion Office. The reason this is important is that the end of the day, our activities belong with the operational leads of the organization. So the people responsible for budgets and staffing are really the ones who are able to enact change. And so our work in the Kaizen Promotion Office is really to work with frontline operations leaders to enact change. Wanted to paint a picture of you for how we operationally make this happen. We're led by a group of the most senior level folks in the organization. They're listed here. I won't go through it in detail, but really this group meets twice a month to talk about the progress of our work. And from there, a subgroup of each of those, so a group from that guiding team, then oversee each one of our value streams. So you would see here that there are executive sponsors in each one of those value streams, and those people are part of that guiding team. So just a few minutes here on the value streams. Wanted to share what they're about, and then I want to actually walk through some of the test of change that we've been running. So the Daily Unified Plan of Care. Sorry, 1 second. I'm just checking here on our chat. It looks like we have some challenges. Could the chairperson please just let me know if the sound is coming through fine on this end? Can you hear me clearly? It sounds like that some folks are having a hard time hearing. Okay, great, thank you. So the three value streams, I'm going to talk about them in a bit of detail. So we have the Daily Unified Plan of Care, the elimination of catheter-associated urinary tract infections, and then just as many of you who work in hospital settings, it's the ever-pervasive issue of getting a patient from the ED to the floor. Without going in too much detail, we're running multi-day improvement events called Rapid Process Improvement Workshops, these RPIWs you see at the bottom of the page. And you see we've held a couple of them for some of these work areas, and there's an ongoing cycle. If you were to look at it over time, it's basically they go every third month. That's how they cycle through. We're gearing up for one next week on transitioning patients from the emergency department to the floor. So I'd like to walk through the value streams a little bit, just for you to get a picture of what the work really looks like for us. This is a high-level look at the patient plan of care. And this value stream, for those of you working in Lean and using similar methods, you'll recognize this. And this is very high level, in a way, kind of like a process map, for those of you familiar with that. And what we're looking at is the cycles of activity that occur, and then the time related to those cycles of activity. So we use time. It's not always the best metric for everything, but it is an objective metric that everybody is held accountable to. So we use it as a starting point. So for example, here we see a patient, their plan of care, where we actually started looking at it initially from their ED admission all the way through to the end, which is a patient plan of care. All those little squiggles, kind of bursts at the top, are all the places where we see variation, and it can go wrong, and it can be different than what than the kind of normal course of work. So again, this is a value stream map for one of our work areas. So the objective of the Unified Plan of Care, and this was agreed upon by the senior leadership back over the summer, is we wanted to create a patient-centered plan, and we want that plan to really be one that engages the patient and that ensures that the team is on the same page throughout the stay. So some of the things they're working on. So the question is, so what are you actually doing? What's different? Here are some of them, and I can talk a little bit more about others. You'll see folks here, they're actually huddling on one of the floors to talk about the plan of care. And what we found with multidisciplinary rounds is we were doing a good job of physically getting together during the day at different times, but weren't necessarily doing it in the patient room, and it wasn't well scripted. And we found that there was value, but to the providers, not always value to the patient, and that they often overran on time, and they didn't always happen at the times that was most helpful, especially for nurses who wanted to update patients on their plan for the day. So you can imagine, for those of you who like to run tests of change and do iterative learning, all of those areas are different ways that we could test. So everything from, as you see in number 5, the patient communication board. We've tested using different language, introducing a glossary to make the language more patient-centered. We've talked about creating a standard work around the bedside RN handoff in the afternoon. And the thing that's actually most recent that isn't on this list is testing a prioritization huddle in the morning at 8 a.m. This is really for patients who have been admitted in the last 12 or 24 hours who don't yet have a plan of care. So we're prioritizing them right out of the chute the first morning that they're there. And for a charge nurse and a physician to meet, to talk about that patient, and then to talk with the patient about their stay, so the patient knows the trajectory often over the next 3 or 4 days on average. So obviously a lot of testing that has to go on there to see what works. On the ED admission to inpatient, again, another value stream. And while you see only 6 of these cloud bursts here, having been living it the last 6 months, I will tell you that there's probably 15 times the number of cloud bursts. So this is a dramatic simplification of it. But I just wanted to share with you what it looks like. You'll notice this is all done by hand, and the purpose is that it's often done with pencil, frankly, because we make a lot of mistakes and we work and rework it. And a lot of our report outs aren't actually in PowerPoint. We just do them in an overhead because we're creating materials kind of on the fly. Certainly a different way of working. It's been invigorating. That ED to admit inpatient care team, their objective is to have a timely and safe transition as soon as the patient is ready. Obviously that sparked a lot of debate, and those of you who work in acute care facilities would perhaps this raises an eyebrow about, well, what does it mean to have it timely, and when is the patient ready, and how safe is safe enough? and that's what we've been testing. So some of those things are about the standard work for the handoff of the emergency medicine physician to the hospitalist. We've developed this method, which you probably have in some of your hospitals, which is a surge. When a hospitalist has a queue of multiple patients waiting to be admitted, that hospitalist can call a surge and pull other hospitalists down from the floor to come down to the ED to see these patients. Much like in a production line, say if factory workers are working on things and they're starting to get behind, they can actually call for help to get back up to speed. We applied the same thinking there. And so on and so forth. So the biggest one really there is around staffing model changes to meet demand, and this has been really one of our biggest challenges. It's making sure that the people we have on and the time of day that they're here really match the patient need, as opposed to either provider preference or just the way things have always been through no fault of their own. Here are some of the tools. Again, we have this cross-coverage beeper as well as that surge plan. And here on the right-hand side, one of the tests of change we ran was about very likely admissions. So could we signal earlier to our hospitalist counterparts to say, here's a sheet for the patients who are definitely going to be admitted. You probably want to know early as possible and get moving on it. This test of change, in complete transparency, didn't end up working out. We found that we didn't need two sheets. We had a white one like this and an orange one. We found that just having them on one sheet was fine, as long as we could signal that information in a better way. So we found that it was actually rework. The last one is around really a safety and infection-related issue. It's the elimination of catheter-associated urinary tract infections. Many of you are probably familiar with this, and it's been a challenge for North Shore Medical Center. And so there have been a few years of work, but really this is the culmination of it, and we've been working pretty fastidiously on it the last 6 months with some really great results. And this is the value stream for it, again. So we create one of these for each of the priority areas. And our goal here is to eliminate the unnecessary use of Foley catheters, indwelling catheters, and the associated urinary tract infections with those. So we've been on a journey to do a few things, and I'm going to share a couple of those tools. So of the first RPIW, the first 5-day improvement event that we ran, we had things like this stop sign that said that we put in the cabinets in the emergency department. So if you're in the emergency department and you're considering putting in an indwelling catheter first, did you consider the alternatives? And on the right-hand side, this is actually, we built this into our emergency medicine management system, MedHost, which is first that nurses have to document an alternative that was tried, and then physicians need to identify the clear indication for catheterization. We completely reworked those indications, that criteria. And what we found, let me see here, that event was in November. So that was specifically for the emergency department, and that was to reduce unnecessary indwelling catheters. We found that the rate of insertion has dropped by 75%, and that for all of the patients that were catheterized, they did meet criteria. So they were in accordance with the criteria that we outlined, and that a physician had written orders and had signed off on them. So really a phenomenal change. We know that this isn't the only area of work for us, inserting indwelling catheters in the ED, but we do know it's one area of work, and we've made significant progress. As a little advertisement for work we just started last month, and we're a couple weeks now into it, reassessment and removal via a nurse-driven protocol on the floor. So for a patient who has an indwelling catheter, do we reassess and remove? We found that applying some lean techniques on saying what information is needed, what information isn't needed, and how do we quickly communicate that information on reassessing an indwelling catheter? How do we communicate that to a physician to say, the patient's met criteria, would you like to remove this indwelling catheter? And we found that the results in a couple of short weeks have been remarkable. that all the patients who've met criteria have had their, I just heard about this today, have had all of their catheters removed within 1 hour of notification of the physician. So great partnership and really removing the catheter as quickly as possible. For those of you not familiar with it, leaving a indwelling catheter in longer dramatically increases the likelihood of infection. So really exciting work, more to come on that, and keeping our eyes on some unintended consequences like the need to recatheterize, but really promising results looking here. I wanted to share in kind of the next 15 minutes or so, with the time that I have left, some learnings from the first year or so of this work. And there are 6, so for those of you following along and wondering how long this is going to go, there are 6 points. The first is the role of senior leadership. And I know this is mentioned basically in any handbook that you pick up and any white paper you look at, that getting senior leadership on board is number one. And I couldn't agree with that any more strongly. The CEO of our president leads our guiding team, so he is the one who ultimately oversees all of this work and pushes our leadership, our senior leadership team on the value streams. Those value streams are led by executive sponsors who are senior vice presidents and some chiefs and chairs. Our CEO has also stated that improvement learning is an expectation of leadership, which may sound obvious, but what it means in reality is a significant time commitment to go through the training and then to learn the methods, teach the methods, and eventually lead events. So lead these multi-day improvement events, which is a significant shift from prior design, I think, for probably many of our organizations. Learning the methods deeply, becoming very knowledgeable, and then leading events was left to people in performance improvement, quality improvement, safety, maybe an operations wing of folks. And here, senior leadership, it's really an expectation is for them to have improvement learning and really the improvement expertise. The last piece here is that our Kaizen promotion office has a mandate from our senior leadership to have a patient at the table for every one of our improvement events. So that's been a challenge to find patients who are available and willing, and when possible, they have experience in the thing we're talking about. So, for example, during one of our events, you can see all the tools on the wall, all of our hard work. We have here one of our senior vice presidents talking with a patient, talking about their experience and really saying, okay, if we're going to work on this area, what's your input? How does this sound? What are your reflections? And alongside them, although maybe not looking like she's quite involved, is one of our physician's assistants from surgery. So the three of them really side by side, a provider, operations, and a patient, talking together about what the change really means. And having the patient in the room and having senior leadership really not just encourage but mandate that occurs dramatically shifts the conversation. I know I probably don't need to tell all of you that, but seeing it in action is really quite powerful. The second learning is really about frontline observation. I've fallen victim to wanting to look at systems data, to pull from the variety of electronic formats that we do have, all the timestamps and all the measurement that we already do, and also being fearful that additional measurement always feels like extra work. But I would argue that we have seen immense value in frontline observation. So for those of us who are trying to improve a particular area, whether it's creating a unified plan of care or transitioning patients safely from the ED or eliminating catheter-associated UTI, really going to observe how the work is done is so much more powerful than getting an Excel spreadsheet readout of 300 patients. Now granted, we use that as well, but the direct observation has been far more powerful. We see the variation in practice, so what is easily, perhaps unexplained when looking at the macro data or just not seen is that variation. To see that before 3 o'clock it happens one way, then at 3:05 it happens another way because of shift change, or that one ED secretary shares 3 pieces of information with bed management, and yet a different ED secretary shares 5 pieces of information, and that makes a big difference. That variation is never captured in that macro data. So here are some of the direct observation tools that we do use. The really short version here is you see a spaghetti map kind of on the top left, really the flow of people or information. And then to the right of it, that's a time observation form. It's really just standing and watching to see what happens. And then the two that are below are really visualizations of the work. Happy to share more comments about that, but won't spend the time today going into the details of what those tools are. But for us, we found that using these tools really helps illuminate where the challenges are and really gives our operational owners a much clearer picture of what is going on in the work area that we're studying. So that leads us to our process owners. These are, in a word, the operational leads, the people who have responsibility at the front line. But when we run a multi-day event, the work doesn't end on Friday afternoon. You know, those 5 days are kind of innovation days and testing days. But for the 1 to 3 months after, there's ongoing testing. And before the event, those are the people helping gather data and developing the current state. So some of those examples are nursing directors, physician champions, case management, a whole variety of people who have served as our process owners. And these are the people who have often some administrative time protected, but they also have some authority within their unit and their division. So as we do carry test of change forward, they have the ability to influence how the test of change what it might look like and how it might be carried out. It's directly related to what we call the home team. So if you're a nursing director on a unit, the home team is that unit. It's the group of people, whether it's emergency medicine physicians, case management team, it's the team that's really testing the ideas. They're the guinea pigs. And whenever we have an improvement event, a multi-day event, the improvement team is the place where we go and test. It's our test bed. And engaging them before the testing is critical to ensure that everybody feels like there is a burning platform for change. And then even after the innovation's been done, they are the place where we continue to test and learn over and measure results over the 90 days that follow. So a home team is an exciting place where testing is done, although it can feel a little bit chaotic because the test of change may vary from week to week. For improvement people, it's a dream because you see rapid cycle testing, but it's a balance for those on the home team. If you're a nurse trying to get your work done, it's the balance of, I'm trying it differently this week than I did the week before and different than the week before that. So certainly a balance for us. Learning about the home team and developing the home team has been a big part of our journey. Number 5 is one that many of us hear in all forms of improvement, which is that unsuccessful change is not the same as failure. And I couldn't quite find the quote, but we don't always improve when we're testing, but we have always learned. And what we've seen is that in areas like the morning huddles, those 8 a.m. prioritization huddles that I mentioned, while they're going better now, we went through many iterations where they weren't working. And prioritizing admissions to the emergency department, that orange form that I showed you, I intentionally raise these because they were ideas that we started and we tested and they didn't work. But what it forced us to say is, if this isn't working, why isn't it working? And what is it we really need to be conveying? What information do we need to be sharing? And it's forced us to go back to the drawing board. That framing is so powerful, and it's obviously connected to senior leadership. We see here a group of folks who are sharing their ideas at a weekly stand-up meeting where they discuss their testing openly. You can see some of their work on the wall behind them. Some of them are taking notes. But really the conversation here is it's about the learning. It's what did we test, what did we learn, and a challenge to say what do we need to test next week to do more learning and to move the dot at the end of the day. So again, connected tightly to senior leadership here is the ability to have an unsuccessful test of change, meaning one that doesn't move the dot in the direction you wanted, as long as senior leadership turns that into a conversation that asks, what do we do next? And that has been really powerful for us. The sixth one here is around accountability. And this is a double-edged sword. Everyone asks for it. Everyone wants it. When you stop people one-on-one in the hallway, they say, oh, if we could just hold this group accountable to their work, we'd be so much better off. And yet, when that accountability comes to them or their friends, it starts to feel like the belt gets real tight. And so some examples of that are we have these, in our journey right now, we have these multi-day events. And from them, so we end on a Friday, and then starting the next week, we have weekly stand-ups. So it's like that picture I showed you a minute ago before. It's that plus 2 or 3 times the number of people where we stand up with senior leadership and we talk weekly about what we're testing and what we're learning for each one of the value streams. That accountability is very visible. It's done in a hallway, so anybody could walk by, stop by, but it's with the guiding team. So that's the CEO, the senior vice presidents, chiefs and chairs, and this is a chance for people to talk about what they've learned, but it's also an accountability to ensure that they've tested and learned something in the past week. The other pieces here, so that's the stand-up wall on the left there. It's our wall of activity. You can just barely see at the very top kind of blue banners. Those are our different value streams. We then have reports to the House at 30, 60, and 90 days. And the details here aren't really the important part. But the point is, while we're doing tests of change every week, it rolls up and we report on what we call a target progress report. That's really a measurement plan, saying what's your outcome measure, what are some of your quality measures, and do you continue to remeasure them 1 month out, 2 months out, 3 months out, and at that point, have you finished the things you said you would work on? So I apologize that it didn't quite animate the way I wanted. I had another document behind it that says newspaper. They kind of stacked on top of each other. The newspaper is just the activities, it's your project management tool. It's the to-do list, but in a different form. And obviously that links very closely that if your theory of belief is that if we close the items out on our newspaper, if we do our to-do list, that we'll start to see some movement on the target progress report. So that's our 30, 60, 90-day plan. Again, high accountability. It's a weekly report out to the senior leadership, and then at 30, 60, 90 days, report outs to the whole organization. Anybody's welcome to come to that. So those are the 6 areas. I just wanted to share in the last couple of minutes that we have before we go to a little bit of discussion, just what our journey has been and where we're headed. You'll see here our relationship with the Virginia Mason Institute and their Virginia Mason Production System. That's the VMPS. That's the phrase they give to their lean journey. You see, we opened our KPO in August on the back of years of other engagements. with other organizations. And we're in the midst now of teaching and training the next level of the organization, so in courses called Lean for Leaders and certification of our leadership. So if I could whittle it down to what the road ahead really looks like before I get into challenges is we're going to be teaching, we'll be training the organization, so we have multiple cohorts of different levels of training. We'll be running events, so that's really the value streams themselves, a rapid process improvement workshop every month. Sustaining those results, so holding people accountable to the work and to the testing, and developing a board at the local unit level, not just this stand-up wall that I showed you, but actually boards at the local level called people link boards, so a unit can see what their work really looks like. And the last is engaging the patient voice in stronger and stronger ways. So I feel really proud that we've had a patient voice in our events, but I believe that we can do a even better job before the event of gathering the patient voice and doing a better job following up with our patients after the event has ended. So I don't want to pat ourselves on the back just yet. I feel like we've made some good progress, but we certainly have more distance to travel on that one. The last is just our challenges. We're trying to manage the old way and the new way right now, and that's a little bit challenging, as you can imagine. It creates conflict, and we're learning our way through a new management method. There's still fear of change, especially related to the complexity of change. So many moving parts to get a patient from the ED to the floor, and the complexity sometimes makes some people feel like it can never be done. And that's a job for us as senior leaders and in the Kaizen promotion office to help make the change manageable for folks. I personally have a challenge with the organization to teach and improve at the same time. So to teach the next level of leaders while improving. And just like I mentioned in the previous slide, it's easy for us to follow the process, but to keep the patient voice in the center of this so that we are challenged not to follow the services we provide by provider or staff member, but to actually follow the experience of the customer, our patient. So that's what I have for today. I came in, I guess, just about right on time given our agenda. I'd turn it over to the other chairs to help facilitate our conversation here. I'm happy to take questions. I think traditionally we do this through the chat method. And
the conference has been unmuted.
So Nicholas, before we do that, just a few housekeeping remarks. Can everyone hear me?
Yes.
Thank you. So just a reminder to leave your webinar screen open until the survey displays. You'll need to finish the survey before you get your CEU credits, which will be mailed to you. So if you need to leave your computer prior to the end of the formal closing of the webinar, just leave the survey up or the webinar up. The survey will remain live on your screen until you complete it. If you're a group participant, you need to do a paper survey and submit that to your group host, and then the group host will submit that to the MAHQ administrator, and the CEU certificates again will be made to you. So Nicholas, I think we're ready for your question and answers.
Great. The floor is for others. I'm here. Maybe I stunned you all into silence.
So I have a question. How are patients feeling about participating in these types of projects?
So the patients that we've engaged have been people with whom we have a relationship already in some way, that it's pre-existing through patient family services. These are patients who are somewhat known to the organization already, at least at this phase in our journey. So we've learned that there are certain things we can do to help orient them to multi-day events. to get even better at that. But I think the overall feedback is, they say, I was intimidated when I was walking in the door on day one to be part of this journey. And by the end of the first day, I felt like I was part of the team. They often reflect on the professionalism and the learning and the excitement that they share. So by the end of the week, we do a report out to the whole house, a 15-minute report on our work. And the patient is one of the presenters. And it's been exciting to see a patient stand up and talk about his or her contribution during the week. So I think they've taken to it quite well. And we've learned every time we've gone as our own kind of test of change to see how we can do it better. Looks like we have a question here from Susan, for those of you who have the chat open, about if the patients can hear. For the value streams themselves, which was the stand-up wall I showed you, that's patients could walk by. It's not on the floor of an inpatient unit, so they're not sitting in their beds hearing it. It is an area that patients walk by, so they could stop. There's certainly nothing stopping them from doing so. The boards that we're developing to be on the floor would certainly be within earshot. Really, the whole point here is that this work is about our patients and should be transparently so. The last piece I'll say is the unified plan of care. We've moved that discussion into the room with the patient. So on that one specifically, yes, it's about the patient, and we very much hope that they're within earshot. We hope it's a conversation with them. Susan, I hope that answered your question. If you have a follow-up, please feel free to chime in there.
So any other questions for Nicholas? So Nicholas, I want to thank you very much. This was very enlightening and very helpful. And thank you to all of the participants. Please again remember to fill out